Hello, I'm Bob Challoner, the President and CEO of Southampton Hospital, and I'd like to welcome you to another edition of Focus on Southampton Hospital, your monthly television programs about the events, people, and happenings at your community hospital. Today we're actually welcoming back a member of our medical staff for a second visit, Dr. Kris Naso. Dr. Kris Naso is a gastroenterologist on our staff. Been with the hospital for a number of years and a very valuable member of our medical staff. And we'd like to talk to Dr. Naso about hepatitis C, a disease that many people hear about, but frequently not so many people know about it, the risks and how to prevent it, how to deal with it. And Dr. Naso has been working in this area for quite a while. So Dr. Naso, thank you very much for being with us today.
Thank you for having me back.
And also, I always like to start off a little bit about you and your background. Tell me about where you trained, and then also how'd you end up in gastroenterology?
Well, I've been out here for 22 years, and prior to that, my training was in Philadelphia and in Brooklyn. Okay. And I actually grew up upstate, which we were just chatting about. Right. And up there, didn't really know much about the East End, but then looked into it at different jobs and found this one that initially I started at Eastern Long Island Hospital, which is on the North Fork.
Oh, okay.
As well as here, well as here. And then I got it was so much busier here that within 8 months I moved my residency to the South Fork, and have been here ever since.
Were you one of the first gastroenterologists here?
There was one or two prior to me. Okay. And then Dr. Casal, who had actually been here for a while, and then he moved back upstate as well. Okay. But no, we've been out here now 22 years. There were 3 of us in part of Meeting House Lane. Yeah, you, Dr.
Georgopoulos, and Dr. Ellis.
Yep.
We have a really great team there. How did you get interested in gastroenterology?
It's interesting. Initially I wanted to be a surgeon, and my focus was that, and then my first residency rotation was with a surgeon, which totally turned me off. Right. And then I just decided, well, this was the next best thing where I could get my hands involved with procedures, and then still do medicine as well. So actually it was a nice combination between the two. And last month we talked about colon cancer screening and procedures, the colonoscopies, things like that. Right. And now we're talking about hepatitis C. Gastroenterologists don't do just procedures, we do other things, and one of them is hepatology, the study of the liver.
That's right. Well, that was one of the things I wanted to start off with, actually, and we all know about GIs, and many of us of a certain age start to think about our colonoscopies, so we start to become very familiar with what GIs do. But I don't think many people realize that hepatitis C and diseases of the liver, and what's the connection there? How come? Because I understand the scoping, the GI system. How does the liver get involved?
Well, it didn't really get that much press initially, and now it is, because hopefully we'll get a chance to talk about new therapies for hepatitis C. Right. I mean, 25 years ago, when I was first going through my studies, in medical school and in fellowship, we didn't even know about hepatitis C. Okay. At that point, it was so-called non-A, non-B. In other words, not hepatitis A, not hepatitis B, but some other virus that we didn't know, because when we tested for those viruses, they were not there. Meanwhile, the patient still had evidence for inflammation of the liver. Okay. So then it went from non-A, non-B to when they finally isolated the virus, and they gave it hepatitis C. Okay. And hepatitis C has actually a number of subtypes. We call them genotypes. Okay. Depending on the genotype, it was the type of treatment. Right. And treatment has tremendously changed over the last 20 years.
Yeah, and I'll be interested to hear about that. I know there's even some very big late-breaking treatments. But first of all, let's talk about, I've heard of hepatitis A, hepatitis B, hepatitis C. What is hepatitis generally?
Hepatitis just is a general term to mean inflammation. Okay. Itis on anything, whether it be diverticulitis or colitis. Itis just means inflammation. Okay. So hepatitis is inflammation of the liver. Right. And it can be from a number of things. It could be from a virus, which is where hepatitis C is from, as is A and B, although they're all 3 different types of viruses and transmitted differently. So it can be from that, it can be from medications, it could be from things that we put into our system, over-the-counter supplements, things like that, can all possibly cause inflammation of the liver, thus hepatitis.
Okay. And I know that Alcohol is a big cause of
Exactly, that's
inflammation
another one, right?
also.
Alcoholic hepatitis, we
Okay.
call it, right.
So hepatitis isn't necessarily a specific disease. It almost sounds like it's a condition caused by different
Exactly,
diseases.
yeah, exactly.
Okay.
It's a general term that could, like I say, from any of those things. And that's where a specialist comes in to try to decipher that,
Okay.
what is actually causing the inflammation of the liver.
Okay. And now hepatitis C, which I know is an area of particular focus for you and gastroenterologists generally these days. How common a disease is it in the United States?
It's actually very common, and the scary part is that most people are unaware that they have it. I mean, it's felt that there's about 4 million Americans that have the disease.
4 million?
4
really?
million.
Right.
Worldwide, maybe 185 million.
Wow.
There's 350,000 deaths a year worldwide relating to hepatitis C.
Okay.
In New York State, it's felt that there is probably 200,000 people that have the disease.
Really?
And the problem with that is the majority of them are unaware of it.
Okay.
It's felt that 75% of people who have the hepatitis C don't even know that they have it.
Really?
And because of that, back in 2013, Governor Cuomo put out a mandate that everyone between the ages of 50 and 70 get tested.
Okay.
So in other words, if you went to your general doctor for your routine checkup, feeling fine, they should be testing you, at one point for hepatitis C. If you got tested last year and it was negative, you don't need it every year. But you should be screened at least once if you're between the ages of 50 and 70.
Well, that was going to be my next question. Who's most at risk for hepatitis C?
Well, for the so-called baby boomers, that's why they came out with this mandate between 50 and 70 years old. But then anybody with high-risk factors, and those would be people who were experimented or continued to use intravenous drugs,
Okay.
because the disease is really spread via blood.
Okay.
So intravenous drug users, people who shared needles, obviously, people who have possibly gotten tattoos, people who got blood transfusions many years ago before we had a test to screen for hepatitis C.
Okay.
Because back then when it was called non-A, non-B,
Right.
we didn't have a test for it. So if someone who had hepatitis C, or at that time non-A, non-B, and gave blood, nobody was able to pick it up.
Okay.
So that's where people who, like hemophiliacs, who gets lots of blood transfusions back in the day,
Right.
would get hepatitis C because they were given blood that was contaminated. Now we don't have that problem because we have all these tests to evaluate for that.
They're able to keep the blood
Exactly.
supply
So if you
safer as a
got a
result.
blood transfusion back then, if high risk factors, like I say, intravenous drug use,
Right.
those folks are the ones that you would screen, as well as the ages between 50 and 70 now.
Okay. And if I'm near somebody or I have a family member that has hepatitis C, how should family members be protected?
Well, actually, I tell all my patients that it's not transmitted by casual contact. It's
Okay.
transmitted by blood.
Right.
So
Sexual contact, is it?
It's very low with sexual contact.
Okay.
There's been studies to show that people, if someone has the disease and their spouse does not,
Right.
that over a 10-year period in a monogamous relationship, that the transmission was less than 15% over that 10-year period.
Okay.
So it's very low. Now we tell people with sexual contact, it's very low. We tell people if you're not to have sexual contact while the woman may be menstruating, because
Okay.
again, you're worried about blood contact.
Okay.
We tell people not to share razor blades, so the person shaves his face, his wife doesn't shave her legs with it, or vice versa.
Right.
Those kind of things. But to hug your kids, kiss them, as you normally would your children, you could even share, food from the table.
Right.
You're not gonna. It's not the so-called like hepatitis A, which is what they call fecal oral. Hepatitis A is contracted orally.
Right.
You take the virus in, whereas hepatitis B and C are again bloodborne.
Okay.
So again, very few things that we worry about transmitting it. You're not going to casual handshake. You're not going to get it on the toilet seat kind of thing that
So
people
not
always talk
spread
about.
if somebody sneezes on you
Yeah, exactly.
necessarily.
Yeah,
Okay.
you're not going to get in a plane full of people who had hepatitis C.
Okay.
You're not going to catch it
Okay.
that way. There's no way.
Well, that explains too, because I've heard about hepatitis being spread through food, but that's a different
Right,
kind
that would
of
be
virus.
hepatitis A is
Okay.
predominantly that way. Exactly.
Okay. And let's talk a little bit about, I'm kind of baffled at the fact that somebody can have it silently. Can you have it silently your whole life, or do the symptoms emerge and at some point, and what are those symptoms?
Yeah, the majority of people have no idea. Like I said, 75% of the people, like in New York State, it's figured that 100 out of those 200,000 people that have it now, 150 don't even know it.
Wow.
That's why we want the screening
testing
of patients who come in just for routine, physical exams.
Right.
So there really aren't symptoms until the disease is far advanced. Okay. The liver has a huge capacity for damage before you start to see side effects.
Right.
So a patient can have hepatitis C for 20, 30 years and not even know it. And then usually the first sign is fatigue. Something very mild is fatigue.
Right.
I kind of equate it when I tell a patient when their liver is diseased for whatever reason, it's kind of like an old car. You can ride that old car,
right.
And she keeps getting you to the store.
Right.
But eventually, it'll keep getting you there. It may be a little clunky along
right.
the way, but it gets you to where you got to go until the wheels fall off.
Okay.
And then you're in trouble.
Okay.
Then we're looking at like transplant, things like that.
Right.
So the majority of people have no symptoms until, much later on.
Liver's a pretty big organ also, isn't it?
Yeah.
I've heard even that people can lose half a liver or
exactly.
something.
And again, that goes back to the ability to damage a lot of it.
Right.
People do give portions of their liver for transplants, whether it be family members
right.
or not. So you can damage a pretty good portion of it and still function, very well and have no real, side effects. So, that's the good thing, with it. But then once you get the damage, severe damage, like I said, when you get around 80, 90% of it being scarred, so-called cirrhosis, that's where you start to get into problems with, the real kind of, side effects. You'll retain fluid,
right.
You'll have difficulty clotting your blood,
okay.
So you may become jaundiced, yellow color. All of those things show a real severe advanced disease. Just
to back up a little bit, because I know sometimes we lay people, certainly, we know we have a liver, we know we have a pancreas, we know we tend to know what our lungs and hearts are for, but some of these other organs, what exactly is the liver doing? And why is it a problem when it becomes disease?
Well, it does, it's kind of like the major filter of the body. The blood all goes through that, filters, it produces your bile, which helps you to digest your food, stored in the gallbladder, and then when you eat, lets that bile come out to help you digest your food. It's involved with, again, cleansing the blood, certain, all kinds of medications and things that we all take for, especially as we, get to our ages, with high blood pressure, diabetes and things. A lot of that is filtered through the liver. So it's a filter of that magnitude where everything kind of goes through there. It helps to clot our blood, among other things. So when you have liver failure, you can't clot your blood, so you're more likely to bleed. So it has a major,
major functions.
Yeah, but you'd be surprised how many other things there are that are involved with the liver itself.
So fatigue, eventually jaundice, dietary problems also, or?
It doesn't really necessarily cause dietary problems in respect that you can still digest pretty much your food because you still have the bile, you still have your pancreas, which does a lot of the digestion, your stomach is still functioning. But the main thing is fluid, gaining fluid, getting inability to clot your blood, just malnutrition, because you are not digesting as quite as good as you will, so you have muscle wasting with that.
Okay.
Those are the main things that you would have with advanced liver disease.
If it sounds like something where the damage starts and sort of accumulates over time, and I'm almost thinking like a filter where it starts to get clogged up over time.
That's a very good analogy.
Can it be, once it's started, can it be stopped and corrected and cured even?
At one point it was felt that there was no regenerative powers.
Okay.
That once you have cirrhosis. Now cirrhosis, just as a general term again, just to mean scarring.
Okay.
So it was felt that once you scar a liver enough that it wouldn't possibly regenerate. But now we're seeing that possibly people who have early damage, not 90% of the liver that is gone, that we may see some people that regenerate to some degree. I've seen people who I thought were going to go on to liver transplant, say for alcohol intake, and they stop right at the right time. That the regenerative abilities is quite amazing, that they turn it totally around and come off a transplant list and never even needed a transplant.
Interesting.
Why one person will do that and one will need a transplant?
Right.
That's something we don't know.
We're all very individualized, aren't we? It almost sounds like there's a tipping point somewhere for each one of us.
There is, yeah.
And Can it actually be cured? Can hepatitis C be cured?
That's that's the nice thing that's happened in the last 2 to 3 years.
Okay.
First of all, 20 years ago, we didn't have any treatments.
Right.
Then we went into this area of interferon and ribavirin.
What would happen 20, 30 years ago? It would just progress till...
Would just progress,
Really?
yeah. You would just watch them.
Really?
You would just, and it's, again, slowly,
Right.
you'd watch them, and you'd see over the years your patient slowly kind of deteriorating.
Right.
That's one of the good and bad things of being in practice, as long as, I
Right.
had for 22 years. You had those patients that 20 years ago, and now
Right.
you've seen them progress.
Right.
So initially we had no therapy.
Right.
Then we started with interferon and ribavirin combination. Interferon was an injection which had major side effects. People were sick, and the treatment could be 6 months to a year.
Wow.
And we only achieved a 30 to 40% success rate.
Wow.
So people were sick for all these years. It was expensive, it was painful.
Right.
The ribavirin caused significant anemia. So people would be out of work for 6 months using these therapies, and then we only had a 30 to 40% success rate.
Wow.
So that was up until a number of years ago, I'd say 2 to 3 years ago, where things dramatically changed.
Okay.
Thanks to actually all of the antiviral work that went into HIV treatment.
Right.
Which actually, interestingly, it's felt now in the last 2 to 3 years, more people are dying from hepatitis C than they are dying from HIV.
I've heard a lot
Yeah.
about the links, and I want to get
they
into
watch
that.
they watch the curves about how many deaths we have from hepatitis C versus HIV, and they crossed, the lines crossed that hepatitis C is now higher than HIV about 2 to 3 years ago.
Really?
We can't cure HIV,
Right.
But now we can actually cure, HCV, which is the other term that we use for it.
For hep C.
So anyway, we went from interferon now to these new antivirals, which have amazing success rates, greater than 95%, depending on what genotype you have.
Okay.
They're very well tolerated. They're oral, so you take a pill, 1 or 2 pills, sometimes up to 4 pills a day.
Right. For how long?
And it's usually anywhere from 8 to 12 weeks. If you have some advanced disease, in other words, you got started after you had progression of your disease, it might be up to 24 weeks.
Okay.
And we're getting 95% success rates.
Really?
Yeah. I mean, I was at a recent conference, and one of the big names in the field said this is a great time to have hepatitis C.
Really?
It's interesting because this was in my lifetime as a physician, the first real chronic disease that I'm seeing cures for.
Really?
I mean, I have colitis, you don't cure colitis. Ulcerative colitis, colon cancer you can cure, but it's not a chronic disease.
Right.
This is the first disease that you're actually curing patients. Patients have been sick for 20 years.
Wow.
And the stigma of having this virus that they could possibly give to someone.
Right.
And now that it's gone.
It's
And
actually gone. That's what's. I
it's
mean, like
gone.
HIV. I know
Right.
there's a sense that it may not show a viral load, but it's still there.
Yeah, the studies have shown that if you're negative, because we can actually measure the quantity of the viral particles.
Okay.
We count the viral particles.
Right.
And when you're out, if it's felt that you first check someone after they're finished, then possibly 12 weeks after they're finished therapy.
Right.
And if it's negative, you test them one more time. And if it's still negative, they have never had anyone revert back after 1 year.
Really?
And the true hepatologists, ones who just deal with the liver, they're
Right.
gastroenterologists who have then specialized just with the liver.
Right. Okay.
They're saying not to go ahead and test any further because it's a cure, which is kind of amazing.
That is amazing.
And it gives me a chill because I have these patients who you don't realize the stigma and the psychological effect that it has
Right.
on them, that they have this chronic disease and now they're
Even with somebody who's had it maybe 20 years or so.
Yeah, that's the
I've seen-
huge part,
Really?
and I can still get a chill from it because
Yeah.
it's they come in truly thankful that they've gotten rid of the disease.
Now, you mentioned depending on your genotype, are there different medications for different genotypes?
Yeah, it's very specialized now.
And it's your genotype or the virus's genotype?
It's the viral genotype,
Okay.
right. There's 1, 2, there's 1A, 1B.
Okay.
It goes up to 5 or 6
Right.
different genotypes,
Right.
depending. In this country, genotype 1 is the most common.
Okay.
Probably 85% of Americans have a genotype 1.
Okay.
Different parts of the world have different genotypes.
Okay.
It's more so in 2 and 3, say in Asia.
Right.
And you do treat, it's very specialized, and there are new medications coming out all the time. This spring, they're looking at 2 more regimens that may come out that they're looking at almost 100% success rate.
Really?
I've had probably, in my practice in the past year and a half, at least 10 cures, probably maybe close to, I shouldn't say that, probably 15 to 20 cures.
Wow.
I've only had one patient where the virus was still active after treatment.
Is it possible for those patients to try a different version of the drug?
Yeah, it depends again on the genotype.
Okay.
And right now, this one patient that I have, we're waiting.
Right.
Because a new regimen is coming out and it's not clear what to do
Right.
with folks with his type of genotype, which regimen to use. We're waiting on those studies.
Okay.
Those studies can take a number of years, but they're probably, for this one patient of mine, we're probably looking at something within a year that hopefully he'll get success with.
Wow, that's amazing.
Yeah.
Very good news, actually.
Yeah.
I've heard the term, you've used the term chronic hepatitis C, and I've heard acute hepatitis C. What's the difference?
Well, acute means that you just contracted it.
Okay.
It's unusual to see a patient with acute hepatitis C because it's not something that usually very often that you're very sick with. It's not like you're jaundiced or have pain. It may just be like you feel like you have the flu.
Right.
Or not even that worse. You got a little, virus of sorts.
Right.
I don't feel right today. That
Right.
kind of thing. You don't have to be sick in bed with 102. You
Right.
usually aren't.
No.
So you don't even know you have it the majority of the time.
Okay.
And then, later on it'll be picked up, again, usually with a routine blood test.
Okay.
So acute just means you got it at that time. Acute hepatitis A, usually you are jaundice. Again, you might get it from food, like a food poisoning per se, but you'll turn yellow
Right.
and you'll be sick for a period. The nice thing about hepatitis A is it's not a chronic disease. The body takes care of it.
Oh, really?
So we don't need to treat hepatitis A.
Doesn't need drugs, really?
No, your body is going to take care of it. You're going to be sick for a while.
Right.
It's like mono. When you get
Right.
mononucleosis, you're sick for a while,
Right.
but your body takes care of it
Right.
the majority of the time.
Okay.
So with hepatitis A, your body will take care of it.
Okay.
Hepatitis B, you may see an acute setting, again, like you're sick with jaundice and maybe fevers. But the majority, probably 85% of that is, again, taken care of by the body.
Okay.
You can have chronic B, and there are medications for that. There hasn't been really any cure for chronic hepatitis B. You have to take chronic medications.
Okay.
I suspect that's going to change now that we have all these new antivirals that are out there. On the other hand, interestingly, the other spectrum for C is that the vast majority of C is chronic.
Okay.
Probably 85% of hepatitis C is going to develop into a chronic disease.
85%. Wow.
Whereas hepatitis A is just the opposite.
Right.
You're going to get rid of all of it.
Right.
B, you're going to get rid of 85% of it. But with
Right.
C, 85% you are stuck. In
Right.
other words, the body's not going to clear it, so we're going to need therapy.
Okay.
10-15% of the time, the body will clear C.
Okay.
So if you get acute hepatitis C, and interesting, I just saw someone who had it, we wait the 6 months
Right.
and see if their body will clear it.
Right.
Clear it means they'll still have this antibody, but when we test their blood for the virus, we can't find the virus.
Okay.
The reason we do that is these medications are very expensive.
Yeah.
The treatments, and Congress is having a big to-do about it because last year, the last 18 months, I just read something about the last 18 months, Medicare, Medicaid spent $8 billion just for these medications. In the last 18 months.
Just for hepatitis
hepatitis
C.
C.
Wow.
Right. It costs on the average about $1,000 a day for these therapies.
Wow.
So you're
and
looking
how
at
long again are people on there?
8 to 12 weeks on
Right,
the average. So you're
okay.
looking at $70,000 to $90,000
Wow.
for the treatment.
Right.
So again, with this person who had acute hepatitis C, we'll wait the 6 months because
Right.
maybe his body won't need it.
Right.
His body will take care of it, and he won't need the therapy.
Right.
And we're not going to cost the system, $90,000.
Right.
But that's the biggest problem right now is the cost of the therapy. It's hoped that as new therapies come on, because there are different companies. Initially, it was just one company,
Right.
and they had all the market, and it was $90,000.
I know some people have I know myself, sometimes I'm sick, I want it cured right away. You start to worry if I wait a little bit. So if you get it and wait 6 months, is there much of a risk? It doesn't sound like the disease progresses that quickly.
It doesn't, and it's rare, very, very rare for the so-called fulminant hepatitis.
Okay.
In other words, the virus is so overwhelming that you're going to go into liver failure.
Okay.
It's one thing for hepatitis, inflammation, but liver failure is, you don't see it
Right.
with these kind of patients, with this kind of virus.
Right.
So it's okay to wait it out and see if their body will clear it on their own.
Right.
The majority of these patients that I'm seeing and curing, they've had it for 15 to 20 years.
Right.
So waiting is not really the issue.
Are there long-term effects after people have had the medication? I mean, I guess the medications are new, so we don't totally know, but some of the symptoms that you described for somebody who has hepatitis C, do those resolve themselves fairly well?
They do. If your liver is in good condition,
Right.
you get rid of the inflammation, and they do really, really well.
Okay.
They feel well. Most of the symptoms that patients have that I'm treating, their main complaint is that of fatigue.
Okay.
And the fatigue will go.
Right.
The side effects of the medication can be some headaches.
That was going to be
the
my
vast
next question.
majority
What are
of
the risks of the
Yeah, the vast
medications?
majority of patients tolerate it so well.
Right.
They don't have to miss work. It's like I said, 1 pill a day, or possibly up to 4 pills a day, depending on the regimen. They don't have to miss work. They feel relatively well. Occasionally headaches.
Okay.
Occasionally a rash.
Right.
The main thing is interaction of the medication with what they're already on.
All right.
Patients, it'll decrease its absorption if patients are on things, acid suppressors, things like omeprazole, people who take it for reflux. We're concerned about, or them taking antacids. We don't like taking the medication along with that.
Okay.
It can possibly affect certain hypertensive medicines. So we have to watch the kind of medication they're taking.
What else they're doing.
When we give them these
They have to be
medicines.
careful about drinking and things also?
Yeah, well, I personally, I won't treat someone if they won't stop their alcohol.
Okay.
Because that's the one big thing that you can do.
Right.
It's been shown that the combination of alcohol and the virus is a nasty combination.
It
And
is.
it will accelerate your disease activity
Okay.
and the progression of damage to the liver.
Okay.
So if there's one thing I could tell anyone, and I'll tell them, if you can't stop drinking, if you can't commit to that, then we're not going to commit to investing $90,000 and the time it takes to get you through this 8 to 12 week period.
Right.
You got to have that kind of a commitment.
Right.
Which is not saying much, considering we can save your life from chronic liver disease.
Absolutely right.
Yeah.
I know alcohol can be very destructive
Yeah.
to the liver over time too. So, is there a vaccine to prevent it, hepatitis C?
There isn't at this point. For that, I would imagine they're going to end up, coming up with something at some point.
Right.
But there is it's not like hepatitis B where you can take a vaccine for
Right.
it. But maybe down the line.
So the vaccine that a lot of people get, we hear about the hepatitis vaccine. That's for B.
That's for
not
hepatitis
C.
B, right?
Okay.
Exactly.
And we're just about out of time, but just a couple of other any advice generally for steps that you would recommend to your patients on one, lifestyle and things they can do to protect themselves, and then when should they get tested if they've got an issue?
Well, I think the main thing is to get screened initially.
Okay.
If you haven't been tested, when you go in for your routine general physical, that once-a-year physical, ask to get the antibody test
Okay.
done. And if it's positive, you'll need another test to prove that you have, we'll have to actually look for the virus.
Right.
Now, your general doctor might be able to do that, or you may need a referral to a specialist.
Okay.
Gastroenterologists do that. Infectious disease physicians treat the disease. So that would be the one thing I would suggest is, prompt your general practitioner, no matter who it is, to test you. It's an easy, go along with your regular blood test. They may take one extra vial, they may not even need to when you get your routine blood work done.
And you mentioned age 50. If somebody's younger and they've maybe been an IV drug abuser or something, would you recommend
Yes.
they get tested younger than 50
By all means,
also?
yeah. I would
Okay.
also test spouses of anybody that had the virus.
Okay.
But yeah, anyone with any risky behavior, whether it be sexually, drug use, it doesn't even have to be intravenous drug use.
Okay.
People who snorted any kind of drug.
Really?
And yes, because the people who would snort cocaine, they have irritation of their nose, and whatever they use to snort it.
Right.
And then
Could be contaminated.
could be contaminated with blood. They give it to the next person to snort, and now you've just passed the blood on the tip of whatever you're using to snort to the next person, and technically the virus as well, possibly.
Wow.
So that's the other risk. Drug patients should be in that.
Great. And Dr. Naso, if locally in the South Fork, we have the ability then to test for Hep C and also help people get the right medication.
It's routine. Yeah, it's routine.
Okay.
Again, the main issue is insurances, but now that there's some more competition,
right.
where initially a year or so ago, a lot of insurance companies weren't treating people,
okay.
waiting to see if they had advanced disease, but now it's gotten much better, and we rarely get a rejection.
Great, good. Well, thank you very, very much for taking the time today and also for the great work you're doing. I know you're doing some amazing things there.
Thank you for having me.
My pleasure. And I'd like to thank everyone for watching today. And if you have a question, you'd like to learn more, please feel free to give Dr. Kris Naso, contact Dr. Kris Naso through our Meeting House offices. We also have Dr. Georgopoulos and Dr. Michael Ellis, all three of whom are well-trained gastroenterologists available to you. They're in the Meeting House Lane practices. Dr. Naso's number is 631-283-0090. I'd like to again thank everyone for watching. I'd like to thank our friends at CTV for producing this show and airing it in our Southampton communities, and also our friends over in East Hampton at LTV for their show. If anyone has any ideas for a future show or question, or just need help navigating the healthcare system here in the South Fork generally, please feel free to give my office a call at 631-726-8555. Thank you, everyone, and good health.